Okay, guys, in this last section, we're going to talk about different classifications of opioids. Opioids can be classified in different classifications based on their structure. Now, every time I look this up, and if you do look this up and try to figure out what class goes with what structure, you're going to see a lot of different nomenclatures. So for that reason, this is FYI, and the fact that I don't want you to know like which ones are phyllanthropines, which ones are phenylpipridines. But what I want you to know, if you have morphine and codeine are the most like each other, as codeine is a prodrug of morphine. So if a patient has an allergy to them, the natural opioids, then you might be able to use semi-synthetic or synthetic opioids. Another thing you want to keep in mind, opioids do have specific classifications, as some are agonists, some are partial agonists, some are mixed agonist-antagonists, and some are antagonists. So just a reminder, agonists include agents that do bind to the opioid receptor and then have activity at them. Partial agonists are those that bind but have low activity. Buprenorphine does have some partial agonist qualities. You have mixed agonist-antagonist, agents that may bind to one and be an agonist, but antagonist at another type of kappa or delta receptor. So we have several agents that are like this, including buprenorphine. And then you have antagonist. The only antagonist that you really have is naloxone, which, of course, you're not going to be using for pain management. So listed here are your partial and mixed versus your agonist. When we look at different opioids, they do have some different properties of each of them. So, for example, morphine is associated with a lot of pruritus. It's because it has the highest amount of histamine release. One of the reasons why we use B monotherapy or Mona-B therapy for patients with cardiovascular disease is because of the histamine release. In patients on morphine with renal insufficiency, you can have an accumulation of these two metabolites, M3G and M6G. M3G is excitatory and M6G is depressive. Now, you might think that they would balance each other out, but usually one will overcome the other, and you can either have the patient have a seizure if they are on opioid, if they're on morphine and have renal dysfunction, or have excessive sedation. So for that reason, you do want to avoid this in renal dysfunction. Codeine has a CYP2D6 polymorphism. It has antitussive effects, and really overall it is a low potency analgesic. The CYP2D6 polymorphism is one of the reasons why it's not used in children anymore. Codeine is a prodrug of morphine. Through to CYP2D6, it becomes morphine. If you have a fast metabolizer, then you are going to have an overdose of morphine. If you have a slow metabolizer, it is not as effective. This occurred in some children where they were fast metabolizers, and so for that reason, it's not used anymore as an antitussive in children. Because it has low potency analgesia, it's a controlled 3 to 5 substance as opposed to the rest of these are C2s. Hydromorphone is a high potency agent, and if you do have renal insufficiency, it does have an accumulation, but this is a non-toxic accumulation. You just have to adjust for it. Oxymorphone is a high potency agent and is the highest potency PO agent available. Hydrocodone is available with formulations of Tylenol, as is oxycodone. And you'll see that they both have are prodrugs of other medications here. So hydrocodone being a prodrug of hydromorphone, and then oxycodone being a prodrug of oxymorphone. The CYP2D6 polymorphisms do not play as big of a role in these compared to codeine, but it is at some points a consideration. Buprenorphine is available IV, PO, and as a transdermal patch. The transdermal patch is primarily used for pain, as the IV is not really used for induction as much as the PO. Now, it can be given interbuccally along with sublingually. It has low intrinsic activity to the mu-opioid receptor, but it has high binding material. That's why it's considered a partial agonist. But it also antagonizes at the delta and kappa, so that's why it has some mixed properties as well. It has a slow dissociation from receptors and has a long duration of action, and so for that reason it makes a really good agent for opioid use disorders. You do need additional credentials to prescribe, but now there's the X waiver that allows more physicians and nurse practitioners to prescribe it for opioid use disorder. And I will leave that to whenever you guys are in psych to learn more about that. It does come in combination with naloxone. The reason is this is an abuse deterrent. So it makes it so that you can't crush it up and snort it or crush it up and inject it. If you look, naloxone, whenever we were showing you the different formulations of it, is either intranasal or IV. And the reason is because it has really poor bioavailability. So keeping that in mind, that if a patient does try to inject or inhale through their nasopharynx passages any naloxone product, including Suboxone, which is naloxone plus buprenorphine, they are going to go into withdrawal. Meperidine isn't really used for pain, and it is against the American Pain Society doesn't recommend it because it has a toxic metabolite, normeperidine, that can accumulate and cause neurosciatory problems, including seizures. In regular doses, it can also cause tachycardia. What it primarily is used for is shivering in operative patients. Methadone has NMDA receptor and monoaminergic reuptake activity, so it has some serotonergic properties as well as NMDA properties. It is extremely long-acting, and it's used in dependence. And if you use it for dependence, you have to go to the special clinic. If you use it for pain, you do not require any special opioid prescribing. Fentanyl is used, and sufentanil and afentanil are all primarily used IV, although there is a transdermal patch available for fentanyl. Also can be used as a lozenge for neck and head cancers. Sufentanil is more potent and afentanil is less potent, but afentanil has a quicker onset of action. These are primarily used for anesthesia in patients. We have other mixed agonists. These are not used very frequently anymore, primarily because of the side effects. If you notice here, they have several agents here have cardiac side effects, including butorphanol and pentazocine, and many of them have psychomimetic side effects. And the reason is because of their actions on the kappa and delta opioid receptors, which are associated with dysphoria. The cardiac side effects may be also related to that as well. And then finally, we have these other agents, tramadol and tapentadol. Both of them have weak to moderate antagonism. Tapentadol is still a control 2 substance. Tramadol is a control 4 substance, being because it has such weak agonist activity. Both of them lower the seizure threshold, and because they both work on serotonin, they do have a risk for serotonin syndrome. Tapentadol has more norepinephrine, so it has more hypertension associated with it, versus tramadol has less and has more serotonergic symptoms. It does get affected. Tramadol does have an effect with the CYP2D6 polymorphism, so that is something you want to consider when looking at agents.